Basics of Medical Biochemistry. First edition, 2022. Chapter 23. Biochemistry of Hormones, Part 4 of 4. By Professor Dr. Muhammad Jawad. MBBS, Dow, M.Phil Philosophy, Ph.D., Dip M.E. 23.13 Adrenal Medulla. It is the central part of the adrenal gland, brownish in color, and constitutes 28% of its mass. It has a neuroectodermal origin. It is composed of closely packed polyhedral cells containing chromaffin granules which are regarded as parent substances for the synthesis of its hormones. The adrenal medulla is innervated by splanchnic nerves and nerve fibers from the lumbar sympathetic chain through the suprarenal plexus. These fibers are preganglionic and cholinergic in nature. The cells of the adrenal medulla act as postganglionic cells and are adrenergic in behavior. The hormone secretory cells of the adrenal medulla are known as chromaffin cells or pheochromocytes. They synthesize and store catecholamines. Epinephrine is made by 90% of medullary cells while only 10% of cells make norepinephrine. These cells also secrete some opioid peptides, metenkephalin, leuenkephalin, and preproenkephalin, but these substances do not cross the blood-brain barrier and their physiological role is not known. 3.13.1 Biosynthesis of adrenal medullary hormones, catecholamines. The hormones of the adrenal medulla are epinephrine or adrenaline. 80 to 85% of stored catecholamines are synthesized primarily in the cells of the adrenal medulla, and another hormone is norepinephrine or noradrenaline. 15 to 20% of stored catecholamines is synthesized and stored not only in adrenal medulla but also in CNS, i.e., peripheral and central adrenergic neurons. The following steps are involved in the synthesis of catecholamines. 1. The first step is the conversion of tyrosine to 3,4-dihydroxyphenylalanine, DOPA, by the enzyme tyrosine hydroxylase. It is the rate-limiting step in the synthesis of catecholamines. The tyrosine hydroxylase worked as oxidoreductase, with tetrahydrobiopterin as a cofactor. It is regulated through feedback inhibition by catecholamines, which compete with the enzyme for the cofactor biopterin. 2. DOPA is decarboxylated to dopamine by aromatic amino acid decarboxylase. Pyridoxal phosphate, PLP, is the cofactor for this reaction. 3. Side chain hydroxylation of dopamine to form norepinephrine is carried out by dopamine beta hydroxylase. 4. Finally, the methylation of norepinephrine takes place by phenylethylamine N-methyltransferase to form epinephrine. The S-adenosylmethionine is used as a methyl donor in this step. Norepinephrine, noradrenaline, epinephrine, adrenaline, and dopamine are collectively known as catecholamines. As catecholamines cannot cross the blood-brain barrier, hence they must be synthesized locally. In certain diseases of CNS, example Parkinson disease, there is a local deficiency of dopamine synthesis. L-DOPA, levodopa, the precursor of dopamine, can readily cross the blood-brain barrier, and so, it is regarded as an important agent in the treatment of Parkinson disease. Storage and secretion of catecholamines. Catecholamines are synthesized in active form and are stored in form of granules in the chromaffin cells of the adrenal medulla. In response to appropriate neural stimulation, these granules are released from cells through exocytosis, and catecholamines are released into the circulation. A several-hour reserve supply of catecholamines exists in chromaffin cells. Epinephrine is secreted by several stressful stimuli such as fear, excitement, hemorrhage, hypoxia, hypoglycemia, etc. Its release is stimulated by cholinergic and beta-adrenergic agents while it is inhibited by alpha-adrenergic agents. Cortisol also promotes the synthesis of epinephrine in the medulla. Cortisol reaches the adrenal medulla and at high levels, the hormone can promote the upregulation of phenylethylamine and methyltransferase, thereby increasing epinephrine synthesis and secretion. The process of the reuptake of the discharged catecholamines is absent in the adrenal medulla. Figure 23.35 Biosynthesis of adrenal medullary hormones, catecholamines. Transport of catecholamines. Catecholamines circulate in plasma in loose association with albumin. They have an extremely short biologic half-life of 2 minutes or less. Very little norepinephrine reaches distal tissues. Epinephrine after the release goes to the liver and skeletal muscles where it is rapidly metabolized. Degradation and excretion of catecholamines. Catecholamines have a half-life of a few minutes when circulating in the blood. They can be degraded either through methylation by catecholomethyltransferase, COMT, or via deamination by monoamine oxidase, MAO, to form inactive O-methylated and deaminate metabolites. These metabolites are further conjugated with glucuronate and sulfate and then excreted in the urine. Less than 5% of epinephrine is excreted directly in urine. Figure 23.36 Degradation of catecholamines, COMT, catecholomethyltransferase, MAO, monoamine oxidase, AO, aldehyde oxidase. 23.13.2 Mechanism of action of catecholamines. They act through cell membrane receptors via a G protein. 4 types of receptors alpha 1, alpha 2, 1, 2 are involved in their actions. Based on these receptors, catecholamine can be classified into 4 main groups. Norepinephrine primarily activates alpha-adrenergic receptors which mediate the increase in Ca2+ influx into the cell, inhibit adenylate cyclase and/or modify the inositol mechanism, while epinephrine activates adrenergic receptors which mediate its effects by increasing in CAMP. Blockers and stimulators of catecholamines. Many therapeutic agents have been devised to either block or stimulate receptors of catecholamines. These are frequently used in the treatment of cardiovascular, psychiatric, neurological, and other clinical disorders. Table 23.14 Blockers and stimulators of catecholamine receptors. Type of receptors. Blockers. Stimulators. 1. Alpha-1. Prazosin, midodrine, methoxamine, and phenylephrine. 2. Alpha-2. Yohimbine, clonidine. 3. 1. Propranolol and atenolol. Dobutamine. 4. 2. Butazamine. Albuterol. Actions of catecholamines. Epinephrine and norepinephrine both cause glycogenolysis in the liver and skeletal muscles, leading to an increase in blood glucose levels. Increase insulin by beta receptors, but decrease insulin by alpha-adrenergic receptors. Mobilization of FFA from adipose tissues and increase in plasma lactate. Stimulation of metabolic rate is brought about by actions of alpha and beta adrenergic receptors. The initial rise in metabolic rate is due to cutaneous vasoconstriction. The decrease in heat loss leads to rising in body temperature. Increased muscular activity. An increase in myocardial contractility mediated via beta-1 receptors may cause extrasystoles and arrhythmias. Norepinephrine causes vasoconstriction in most if not all organs via alpha receptors, leading to an increase in total peripheral resistance, but epinephrine dilates the blood vessels in skeletal muscle and the liver via beta receptors. As a result, there is a decrease in total peripheral resistance. Sphincter contraction in GIT and urinary bladder. Smooth muscles relaxation in the uterus and bronchioles. Respiratory rate and depth both are increased. Pupillary dilatation and retraction of eyelids. The action of thyroid hormone is increased and vice versa. Epinephrine and norepinephrine cause an initial rise in plasma K+ via its release from the liver, and then a prolonged fall of plasma K+ occurs because of an increased entry of K+ into skeletal muscle that is mediated by beta-adrenergic receptors. Table 23.15 Cardiovascular effects of epinephrine and norepinephrine. Upward arrow, increase, downward arrow, decrease, N, normal. Catecholamine. Blood pressure. Cardiac. Output. Heart rate. Total. Peripheral vascular resistance. Systolic. Diastolic. Pulse. Mean. Epinephrine. Upward arrow. Downward arrow or N. Upward arrow. Upward arrow. Upward arrow. Upward arrow. Upward arrow. Downward arrow. Norepinephrine. Upward arrow. 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 Downward arrow. Downward arrow. Downward arrow. Upward arrow. Upward arrow. Upward arrow. Dopamine. It causes vasodilatation in renal, splanchnic, coronary, and cerebral vessels by D1 dopaminergic receptors. It has a positive inotropic effect on the heart and increases the systolic blood pressure but does not affect the diastolic blood pressure. It also causes natriuresis and inhibits Na plus K plus ATPase. It is used in the treatment of traumatic and cardiogenic shock. The deficiency of dopamine in basal ganglia causes Parkinson disease, which is treated by LDOPA, levodopa. Regulation of secretion. A physiologic stimulus affects adrenal medullary secretion through the nervous system. Secretion is reduced in sleep and increased in emergencies to prepare the body for fight or flight. Secretion is increased in all situations of stress such as anxiety, pain, fear, emotional excitement, exposure to cold, hypotension, and hypoglycemia. Only epinephrine is released. These stressful conditions stimulate certain areas of the hypothalamus to release the corticotropin-releasing hormone. Stimulatory impulses from the hypothalamus reach to adrenal medulla through its sympathetic cholinergic nerve supply, resulting in the copious release of catecholamines, mainly epinephrine, into the circulation. 23.13.3 Pheochromocytoma. This is a tumor of the adrenal medulla, which is usually benign, vascular, and encapsulated. It is also known as medullary chromophinema or chromophine cell tumor. It overproduces mostly norepinephrine and to some extent epinephrine. The main symptoms are continuous or intermittent high blood pressure, palpitations, weight loss, sweating, flushing, numbness, headache, blurring of vision, and chest pain. Blood pressure may reach up to 250/150 mmHg in untreated cases. Death may occur due to pulmonary edema, cerebral hemorrhage, or ventricular fibrillation. Laboratory evaluation of adrenal function. 1 measurement of serum ACTH. Under normal circumstances, it is higher in the morning than in the evening due to diurnal rhythm. It is found high in Addison's disease but low in Cushing's syndrome. 2. Measurement of plasma cortisol. It has the same diurnal rhythm as ACTH. It is found low in Addison's disease but high in Cushing's syndrome. 3. ACTH stimulation test. This test measures how well the adrenal glands respond to ACTH. The ACTH stimulation test is used to diagnose adrenal insufficiency, such as Addison's disease. In this test, high dose of ACTH is given over a prolonged period to produce a maximum ACTH stimulation. In normal cases, plasma cortisol may rise to 10 times. This shows a normal response of the adrenal cortex to ACTH. It is also used to determine if the pituitary gland is not working properly due to hypopituitarism. The deficiency of cortisol could alternately be a cause of secondary adrenal insufficiency. 4. Dexamethasone suppression test. This test is based on the ability of dexamethasone to suppress the pituitary gland, thereby reducing adrenal gland stimulation. First, a urine sample is tested for cortisol. Then dexamethasone is given, and cortisol levels are measured in another sample of urine. If Cushing's syndrome is caused by pituitary stimulation, the level of cortisol will fall. If Cushing's syndrome is caused by stimulation from a non-pituitary source of corticotrophin or an adrenal tumor, the urinary cortisol level will remain high. 5. Determination of aldosterone to renin activity ratio. It is the ratio of plasma aldosterone, expressed in Ng/dl, to plasma renin activity, expressed in Ng/ml/h, and is the most sensitive means of differentiating primary from secondary to causes of hyperaldosteronism. Normal range of plasma aldosterone level is 2 to 9 Ng/dl. For a normal sodium diet, the normal range of renin activity is 0.6 to 4.3 Ng/ml/h. Aldosterone to renin activity ratio of greater than 25 is suggestive of primary hyperaldosteronism. It is used to diagnose Conn's syndrome. 6. Estimation of vanillomandelic acid. VMA. Vanillomandelic acid is one of the breakdown products, metabolites, of epinephrine and norepinephrine. It is used to detect tumors called neuroblastomas and other neuroendocrine tumors. 24 hours urinary VMA is raised in pheochromocytoma. 7. Estimation of metanephrine. This test measures the amount of metanephrine in urine over 24 hours. Metanephrine is the breaks-down product of epinephrine. Along with VMA, it is also raised in pheochromocytoma. Normal levels of metanephrine in plasma are 0.5 nmol/L and in 24-hour urine are 0.3 to 0.9 nmol/L. 8. Measurement of urinary 17-hydroxycorticosteroids. It is raised in Cushing's syndrome. Table 23.16 Lab findings in adrenal disorders. S.No. Type of disorder. Lab investigations and findings. 1. Addison's disease. Hyponatremia Ie, downward arrow Na+. Hyperkalemia Ie, upward arrow K+. Hypovolemia. Acidosis. 2. Cushing's syndrome. Increased serum and urinary free cortisol. Loss of usual circadian rhythm. Loss of suppression of cortisol production in dexamethasone suppression test. Hyperglycemia. Increased urinary 17-hydroxycorticosteroids. 3. Conn's syndrome. Hypernatremia. Hypokalemia. Increased aldosterone/renin activity ratio. Alkalosis. 4. Pheochromocytoma. Increased plasma catecholamines. Increased urinary VMA. Increased plasma and urinary metanephrine. 5. Congenital adrenal hyperplasia, CAH. Due to 21-alpha-hydroxylase deficiency. Markedly increased urinary pregnenatriol. And 17 ketosteroids. Increased plasma 17-hydroxyprogesterone. 6. Congenital adrenal hyperplasia, CAH. Due to 11-beta-hydroxylase deficiency. Increased serum 11-deoxycortisol. Increased urinary 17-hydroxycorticosteroids and 17 ketosteroids. 23.14 The pineal gland and melatonin. It is a small gland of about 120 mg weight, also known as epiphysis cerebri. It is an outgrowth of the roof of the diencephalon. It is found near the posterior margin of the corpus callosum, slightly cranial, and superior to the cerebellum. It has a rich arterial supply as circulus arteriosus cerebri. Venous drainage is by cavernous venous sinus. It is composed of two cell types, pinealocytes, about 95% of the cells, a large, light, and round nuclei, and astrocytes, glial cells, dark, elongated nuclei. The pinealocyte cells that make up the pineal gland are known to produce and secrete the amine hormone melatonin, which is derived from serotonin. The soft tissue of the adult pineal gland contains more fluoride than any other soft tissue in the body, a level of fluoride capable of inhibiting enzymes. The pineal gland also contains hard tissue, hydroxyapatite crystals, which accumulates more fluoride than any other hard tissue in the body, for example teeth and bone. Studies show that fluoride reduces the levels of melatonin in the blood. The glandular tissue of the pineal gland is predominated in children and young adults. It regresses with age and becomes fibrous and calcified. It is also known as the third eye because its influence on secretory activity is related to the amount of light entering the eyes. 23.14.1 Biosynthesis of melatonin. The circulating amino acid L-tryptophan is the precursor of melatonin. Within pineal cells, it is converted to serotonin by a two-step process, catalyzed by the enzymes tryptophan hydroxylase and 5-hydroxytryptophan decarboxylase. Pineal serotonin concentrations in mammals are high during the daily light phase and decrease during the dark phase when much of this indolemine is converted into melatonin. This process, which occurs principally but not exclusively in the pineal gland, example also in the retina, involves serotonin's N-acetylation, catalyzed by an N-acetyltransferase enzyme, and its subsequent methylation by hydroxyindolomethyltransferase. Figure 23.37 Biosynthesis of melatonin. Postganglionic fibers reaching the pineal organ via the nervi coronari release norepinephrine at night. This neurotransmitter then activates adenylate cyclase, stimulating the production of the second messenger cyclic adenosine monophosphate, CAMP, which accelerates melatonin synthesis. The serum melatonin levels in humans exhibit a characteristic daily pattern. Levels are very low during the day, 0.5 to 3 pg/ml, and can be as high as 200 pg/ml at night, with typical nighttime levels in adults of about 100 pg/ml. Regulation of melatonin secretion. The secretion of melatonin is mainly regulated by light. It varies according to the level of light received from the environment. When photons of light stimulate the retinas of the eyes, a nerve impulse is sent to a region of the hypothalamus called the suprachiasmatic nucleus, SCN, which is important in regulating biological rhythms. From the SCN, the nerve signal is carried to the spinal cord and eventually to the pineal gland, where the production of melatonin is inhibited. As a result, blood levels of melatonin fall, promoting wakefulness. In contrast, as light levels decline in the evening, melatonin production increases, which produce drowsiness. Actions of melatonin. The pineal gland and its hormone melatonin are important components of the systems that organize rhythmic biochemical, physiologic, and behavioral processes in living organisms. Melatonin is a highly lipophilic hormone, permitting its ready penetration of biologic membranes and its ability to reach each cell in the body. The effects of melatonin appear to be mediated via specific melatonin receptors, two of which, MT1 and MT2, have been cloned and characterized in mammals. 1. Regulation of circadian rhythm. The circadian rhythm of the body is significantly influenced by the secretion of melatonin. This dark light fluctuation not only affects sleepiness and wakefulness, but also appetite and body temperature. Since the activity of the pineal gland depends on the amount of available energy, it is a photosensitive organ. 2. Secretion of melatonin by the pineal gland inhibits the secretion of the gonadotropin-releasing hormone, GnRH, by the hypothalamus. Secretion of melatonin also indirectly inhibits the pituitary from secreting gonadotropins, luteinizing hormone, LH, and follicle-stimulating hormone, FSH, because the secretion of GnRH is necessary for this to occur. Because its secretion reduces the levels of LH in the blood, melatonin may inhibit ovulation in women and can decrease sperm mobility and sex drive in men. By inhibiting the secretion of gonadotropins, hormones that regulate normal growth, sexual development, and reproductive functions, before puberty, melatonin prevents the onset of puberty before the appropriate age. 3. It suppresses the growth of many glands like the pituitary, thyroid, adrenal, etc. An increase in weight and overactivity of these glands are observed in pinealectomized animals. 4. Melatonin levels are low in children with autism, and as a result, about 70% of them suffer from sleeping problems. Studies show that low doses of melatonin can help children with autism sleep better without giving them any noticeable side effects. 5 studies revealed that melatonin levels may be related to the risk of certain types of cancer. Melatonin levels tend to be lower in women with breast cancer than in those without the disease. Laboratory experiments show that low levels of melatonin stimulate the growth of certain types of breast cancer cells. However, adding melatonin to these cells slows their growth. 6. Act as an antioxidant. It is a powerful antioxidant that can easily pass through cell membranes and the blood-brain barrier. It is a highly effective and direct scavenger of very reactive and toxic free radicals. Unlike other antioxidants, melatonin does not undergo redox cycling. Once it is oxidized, it can never be reduced to its former state. Therefore, it never promotes free radical formation. By terminally disarming the free radicals, melatonin protects the DNA of cells from oxidation damage. 7. Some investigators have proposed that melatonin might affect immune function, aging, tumor growth, and certain psychiatric disorders. 3.14.2 Pineal gland disorders. One of the problems of the pineal gland is delayed circadian rhythm, DCR, disorder. DCR constitutes a mismatch between the external and internal clocks of the affected person. In this disorder, the internal clock runs slower than a normal circadian rhythm, which is 24 hours, so the body does not wake up until later in the morning or day. When this occurs in the body, the pineal gland releases the nighttime hormone, melatonin, too late, often causing the individual to fall asleep later. When it is time to wake up, the body clock believes it's only midnight and is still producing the nighttime hormones. As a result of this disorder, a person may experience the following symptoms: difficulty in getting and maintaining sleep, late night insomnia, a general feeling of laziness in the morning, an increase in alertness in the evening or late at night, difficulty concentrating, being alert, or accomplishing tasks. Some DCR sufferers oversleep and have trouble getting up on time. Treatment is by dawn simulation, which helps people to maintain a steady circadian rhythm by exposing their internal body clocks to a properly timed signal of light through their retina. The light gradually becomes brighter, simulating a sunrise, to reset the body clock while not too bright to cause premature awakening. Advanced circadian rhythm, ACR, disorder is the opposite of DCR. In ACR, the internal body clock runs faster than a normal circadian rhythm. The patient tends to run out of energy before their day is up. ACR compresses the sleep portion of the daily cycle, causing an individual to lose valuable sleep. ACR sufferers often sleep less than 8 hours per night and awaken early. In this problem, the pineal gland releases melatonin too soon, causing tiredness earlier in the day. Then, because melatonin is released prematurely, the patient is unable to maintain a complete sleep cycle, and he or she wakes up too early. As a result of this disorder, a person may experience the following symptoms: early morning awakening and/or early morning insomnia, inconsistent sleep with one or more sleepless periods during the night, lack of energy during the day, feeling tired in the early afternoon and/or evening. Alertness and ability to function may also be diminished. Some ACR-affected persons may not notice a sleep problem but lose energy and feel tired in the afternoon or evening time. Treatment: specialized bright light is the only effective treatment for ACR. Bright light inhibits the release of melatonin for about 3 hours. Use bright light in the late afternoon and evening and avoid bright morning light before 9 a.m. Wearing sunglasses is required if the patient is exposed to bright light early in the morning and makes nighttime as dark as possible. The deficiency of melatonin may cause precocious puberty. This is a problem because melatonin is responsible for inhibiting the actions of the gonadotropins. Precocious puberty is an unusually early onset of puberty beginning before age 8 for girls and before age 9 for boys. If left untreated, children will become able to reproduce and will stop growing too soon. Symptoms for girls are early breast development and an early start of menstruation. Symptoms for boys are enlarged testicles and penis, facial hair, and deepening of the voice. Other symptoms observed both in boys and girls are pubic or underarm hair, rapid growth, acne, and adult body odor. If precocious puberty is caused by abnormally low melatonin levels, melatonin supplements can be a very successful form of treatment. Treatment is very important because precocious puberty will prevent children from reaching their full height because they stop growing too early. Achievement of puberty before the corresponding age can also have negative psychological effects on children, including low self-esteem and depression. 23.15 Thymus gland. It is a small gland that is pinkish-gray color in children and yellow in adults. It is about 5 cm long at birth and continuously grows during childhood. It begins to steadily atrophy after puberty until it is ultimately replaced by adipose tissue. It is the largest and most active in children. Its maximum weight is at puberty, which is about 20 to 37 grams. It is located in the upper part of the chest, behind the breastbone, and is made up of two lobes that join in front of the trachea. It is enclosed in a protective capsule. Internally it is divided into two parts, the outer cortex, and the inner medulla. The thymus gland secretes a hormone called thymosin. This hormone stimulates T cells in other lymphatic organs to mature. These cells are then transported to various lymph glands, where they play an important part in fighting infections and disease. Thymosin also plays a role in the initiation of the aging process. If the development of the thymus is hindered in any way in the fetus, the whole immune system cannot develop. It also produces thymopoietin, TMPO, another hormone that is a protein present in the mRNA and is encoded by the TMPO gene. Thymus cancer. It develops when cancer cells form on the outer surface of the thymus gland. There are primarily two kinds of cancer that can arise in the thymus. The first type involves a thymoma, a tumor whose cancerous cells look like normal thymus tissue. Thymomas are linked to autoimmune diseases which cause the immune system to attack healthy tissue. The second sort of thymus cancer includes thymic carcinomas, tumors that contain cells that do not look like thymus cells. Thymic carcinomas are exceptionally dangerous because they grow more quickly and more probably extend to other tissues. Both thymomas and thymic carcinomas can be present in an individual without presenting any symptoms and may only be found in a routine chest X-ray. But when symptoms do occur, it is most commonly in the form of a continuous cough, chest pain, and difficulty in breathing. Digeorge syndrome, thymic dysplasia. It is a rare congenital defect that causes dysfunction of several different tissues. Patients with Digeorge syndrome have a small deletion on their 22nd chromosome, known as 22q11.2, which contains between 20 and 30 genes responsible for the development of different parts of the body. Most often Digeorge syndrome is associated with a very small or absent thymus gland. Patients of Digeorge syndrome have very weak immune systems and are extremely prone to infections. They need to receive a thymus transplant or receive infusions of immune cells to help prevent dangerous infections. Relationship between myasthenia gravis and thymus gland. Myasthenia gravis is a chronic autoimmune neuromuscular disease characterized by varying degrees of weakness of the skeletal muscles. It is caused by a transmission malfunction of nerve impulses to the muscles. It is most common in women under 40 and men over 60 years of age. In myasthenia gravis, antibodies produced by the body's immune system obstruct, change, or destroy the receptors for acetylcholine at the neuromuscular junction, which inhibits the muscle from contracting. In adults with myasthenia gravis, the thymus gland remains large and is abnormal. It contains certain clusters of immune cells indicative of lymphoid hyperplasia, a condition usually found only in the spleen and lymph nodes during an active immune response. Some may develop thymomas which are generally benign but can become malignant. The relationship between the thymus gland and myasthenia gravis is not yet fully understood. Scientists believed that the thymus gland may give incorrect instructions to developing immune cells, ultimately resulting in autoimmunity and the production of the acetylcholine receptor antibodies, thereby setting the stage for the attack on neuromuscular transmission. Thymectomy, the surgical removal of the thymus gland, reduces symptoms in some individuals without thymoma and may cure some people, possibly by rebalancing the immune system. 23.16 Hormones of GIT. These are the chemical messengers that regulate intestinal and pancreatic function, including regulation of secretion, motility, absorption, digestion, and cell proliferation. These hormones are secreted by endocrine cells, which are widely distributed throughout the GI mucosa and pancreas. GI hormones may also serve as transmitting agents for nervous impulses discharged into blood vessels after nervous stimulation in a true neurocrine mode. It is to be noted that GI hormones are also synthesized in the brain. These hormones can be divided into three main groups based on their chemical structure. 1. Gastrin cholecystokinin family, gastrin and cholecystokinin. 2. Secretin family, secretin, glucagon, vasoactive intestinal peptide, and gastric inhibitory peptide. 3. Peptide family, somatostatin, motilin, and substance P. Factors that influence the secretion of gastrointestinal hormones are 1. Odor, taste, and ingestion of food mediated by the vagus nerve. 2. Distension of stomach. 3. Partial digestion products of protein in the stomach causes gastrin to be released from the antral mucosa, which in turn causes the secretion of highly acidic gastric juice. 4. The presence of protein in the small intestine also stimulates gastric secretion via a humoral mechanism. 5. The presence of chyme in the upper small intestine causes the release of several intestinal hormones. 6. The presence of proteases and peptones, which are products of partial protein digestion, and of long-chain fatty acids, and hydrochloric acid from the stomach juices also causes cholecystokinin released in small quantities. Gastrin. It is a peptide of 34 amino acid residues. It is secreted mainly by the G cells of the pyloric glands of the stomach and to a lesser extent by the duodenum and jejunum. In the fetus, the islet of Langerhans also secretes this hormone. Human progastrin, the precursor of gastrin, consists of a 21 amino acid signal peptide, a 37 amino acid N-terminal extension, the gastrin 34 sequence, and a 9 amino acid C-terminal extension. Post-translational modifications of progastrin to gastrin take place in the endoplasmic reticulum. Gastrin is the main physiological regulator of gastric acid secretion and an important regulator of gastric mucosal cell proliferation. It also stimulates the secretion of glucagon. Gastrin release is stimulated by food components, particularly aromatic amino acids and amine derivatives of amino acids, and is inhibited by luminal acid. The entry of food into the stomach results in vagal stimulation and the release of gastrin hormone. Gastrin hormone stimulates two types of cells in the stomach, parietal cells to secrete HCl, and chief cells to secrete an active zymogen called pepsinogen. Cholecystokinin, CCK. It is made up of 39 amino acid residues. It is secreted by I cells of the duodenum and jejunum. The entry of acidic chyme into the small intestine stimulates the release of secretin and cholecystokinin hormones. Cholecystokinin is responsible for gallbladder secretions, gastrointestinal motility as well as pancreatic exocrine secretions. CCK hormone stimulates the release of pancreatic zymogens, trypsinogen, chymotrypsinogen, procarboxypeptidase, proelastase, and procollagenase. The pancreatic secretion occurs under the influence of CCK and is rich in HCO3 and pancreatic enzymes. Like gastrin, it also stimulates the secretion of glucagon. CCK receptors have been identified in the brain and certain peripheral tissues, where they activate phospholipase C. Secretin, it is a peptide hormone with 27 amino acid residues, synthesized as a 120 amino acid precursor protein also known as prosecretin. It was the first substance to be named a hormone in 1902. The secretin is produced by S cells of the duodenum and jejunum. When hydrochloric acid passes from the stomach into the duodenum, secretin is released into the bloodstream and stimulates the duct cells of the pancreas to secrete water and bicarbonate. It stimulates the release of pancreatic juice rich in bicarbonate to neutralize gastric secretion. Its action is mediated through the CAMP pathway. It also inhibits the HCl secretion and gastric emptying but stimulates the secretion of duodenal glands. Gastric inhibitory peptide, GIP. It is a peptide hormone composed of 42 amino acid residues, also known as a glucose-dependent insulinotropic polypeptide. It is produced by K cells of the duodenum and jejunum. It is an inhibiting hormone of the secretin family of hormones. While it is a weak inhibitor of gastric acid secretion, its main role is to stimulate insulin secretion. It has been named gastrointestinal inhibitory peptide or gastric inhibitory peptide, because of its ability to decrease the secretion of stomach acid to protect the small intestine from acid damage, reduce the rate at which food is transferred through the stomach, and inhibit the GI motility and secretion of acid. Vasoactive intestinal peptide, VIP. It is a 28 amino acids containing peptide that is structurally similar to secretin, glucagon, and GIP. It is a neuropeptide that is found in neurons of GIT, brain, and autonomic nerves. It acts as a neuromodulator and neurotransmitter. It is a potent vasodilator that regulates smooth muscle activity, epithelial cell secretion, and blood flow in the gastrointestinal tract. It has many actions in the body, such as helping to control the secretion of water, salts, enzymes, and gastric acid during digestion. Certain tumors in the pancreas make large amounts of the vasoactive intestinal peptide. A vipoma is a non-beta pancreatic islet cell tumor secreting vasoactive intestinal peptide, VIP, resulting in a syndrome of watery diarrhea, hypokalemia, and achlorhydria. Melatonin. It is a peptide hormone of 22 amino acid residues. It is actively involved in controlling the pattern of smooth muscle contractions in the upper gastrointestinal tract. There are two basic states of motility of the stomach and small intestine, the fed state, when foodstuffs are present, and the partial digestive state between meals. Melatonin is secreted into the circulation during the fasted state at intervals of roughly 100 minutes. So, it appears to be the chief regulator of GIT motility in between meals. Substance P. It is a neurotransmitter with 11 amino acid residues. It is a member of the tachykinin neuropeptide family and acts as a neuromodulator. Is synthesized in cell bodies of vagal sensory ganglia and transported bidirectionally toward the CNS and thoracic and abdominal viscera. It stimulates the motility of the small intestine. Glycentin and glucagon. Glycentin is a 69 amino acid N-terminal peptide, derived from proglucagon by post-translational processing in the intestine. It is produced by L cells of the intestinal mucosa. It has glucagon-like activity. Glucagon is also derived from proglucagon but is secreted by alpha cells of islets of Langerhans of the pancreas and to a lesser extent in the stomach and duodenum. Somatostatin. It is secreted in two forms, one with 14 amino acids and another with 28 amino acids. Also known as growth hormone inhibiting hormone, GHIH. It regulates the endocrine system and affects neurotransmission and cell proliferation via interaction with G-protein-coupled somatostatin receptors. Somatostatin is a hormone produced by many tissues in the body, principally in the nervous and digestive systems. It regulates a wide variety of physiological functions and inhibits the secretion of other hormones, the activity of the gastrointestinal tract, and the rapid reproduction of normal and tumor cells. Its release is stimulated by increased plasma amino acids, fatty acids, and glucose. Somatostatin release is also stimulated by GI hormones. Somatostatin inhibits the release of both insulin and glucagon, and it decreases activity and secretion by the GI tract. In the pancreas, somatostatin is produced by the delta cells of the islets of Langerhans, where it serves to block the secretion of both insulin and glucagon from adjacent cells. Somatostatin affects the pituitary gland in that it causes inhibition of secretion of growth hormone, which is vital to cells in growth and metabolism. It is a potent inhibitor of gastrin-stimulated acid secretion by activation of somatostatin receptor type 2 and also inhibits the contraction of the gallbladder. Clinical aspect: somatostatin is frequently used as an effective vasoconstrictor for the treatment of esophageal varices to control bleeding. Vasoconstrictors can reduce portal blood flow and or increase resistance to variceal blood flow inside the varices. Therefore, these drugs reduce blood flow in the gastroesophageal collaterals because of their vasoactive effects on the splanchnic vascular system. Guanylin: it is a 15 amino acid polypeptide that is secreted by goblet cells in the colon. It acts as an agonist of the guanylyl cyclase receptor GCC and regulates electrolyte and water transport in intestinal and renal epithelia. Pancreatic polypeptide, PP: it is a polypeptide of 36 amino acid residues. It is produced and secreted by PP cells, originally termed F cells, of the pancreas, which are primarily located in the islets of Langerhans. The function of PP is to regulate both endocrine and exocrine pancreatic secretion. Ghrelin: it is a recently discovered hormone, is a polypeptide having 28 amino acids. Ghrelin is a hormone that is produced and released mainly by the stomach, with small amounts also released by the small intestine, pancreas, and brain. Its receptors are found in the hypothalamus. Ghrelin has numerous functions. It is termed the hunger hormone because it stimulates appetite, increases food intake, and promotes fat storage. Peptide Yy: it is the polypeptide chain of 36 amino acid residues. It is structurally related to pancreatic polypeptide and neuropeptide. It is released from cells in the ileum and colon in response to their filling. PYY acts as an anorexigenic to reduce appetite. Therapeutic uses of GI hormones. GI secretions and GI hormones have been used clinically as both diagnostic and therapeutic agents. For example, the administration of CCK8 can help to establish the diagnosis of biliary colic. The administration of secretin has been useful in the diagnosis of equivocal patients with the Zollinger-Ellison syndrome, and administration of Gastrin has been useful to assess maximal acid output in patients in whom the diagnosis of Zollinger-Ellison syndrome is being considered. Somatostatin is the GI peptide that has been used most extensively. Somatostatin analogues have been used to decrease pancreatic and GI secretions associated with fistulas. In addition, somatostatin therapy provides symptomatic relief from hormone overproduction secondary to carcinoid tumors or other endocrine-producing tumors. Furthermore, octreotide radionucleotide scans provide useful diagnostic tools to identify endocrine tumors. GI hormones may have direct clinical applicability to diseases of the non-neoplastic GI tract and pancreas. Agents that block hormone receptors or hormone release may be useful as a potential adjuvant therapy in patients with GI malignancies. As more specific and longer-acting agents are developed, it is anticipated that the use of GI hormones or antagonists, depending on the clinical scenario, may provide novel therapies for various GI diseases. Summary: endocrinology is the study of hormones and their role in the biological functions of the body. Principal functions of the endocrine system are maintenance of the internal environment in the body, integration and regulation of growth and development, maintenance and initiation of sexual reproduction and development, and nourishment of the newborn. A hormone is a chemical substance released from living cells that travels some distance to target tissues to have a biological control and regulatory effect on other cells of the body. Hormones can be classified according to the mode of action, chemical nature, and mechanism of action. Steroid hormones such as testosterone, cortisol, and vitamin D3 or cholecalciferol are derived from cholesterol. Amino acid derivative hormones include thyroid hormones, catecholamines, and melatonin. The action of thyroid and steroid hormones is mediated by forming a hormone receptor complex. Hormones that act by stimulating CAMP formation are TSH, MSH, CRH, ACTH, FSH, LH, HCG, calcitonin, glucagon, PTH, and adrenergic catecholamines. Hormones that act by inhibiting CAMP formation are somatostatin, angiotensin II, alpha-2 adrenergic catecholamines etc. Hormones acting through cGMP are ANP, BNP, CNP, and nitric oxide, NO. A hormone usually affects only a limited number of cells, called target cells, which respond to a hormone because they bear receptors for the hormone. Hormone receptors are dynamic in nature and their number responds to physiological and biochemical factors. Thyroid and steroid hormones act through intracellular receptors. Protein and peptide hormones like catecholamines such as epinephrine and eicosanoids such as prostaglandins, hydrophilic, find their receptors on the plasma membrane of target cells. Some hormones act on receptors with an intrinsic tyrosine kinase activity such as insulin, which has a protein kinase activity in its cytoplasmic domain. A biological half-life is a time taken by a substance such as a hormone or a drug to lose half of its pharmacologic or physiologic activity. The onset of hormone action may be immediate, delayed, or both. For example, the immediate effect of ACTH is the sudden release of cortisol while its delayed effects are hypertrophy and hyperplasia of the adrenal cortex. Hormonal rhythms and pulsatility are the adaptations of hormonal secretions to environmental changes, such as seasons of the year, the daily light-dark cycle, sleep, meals and stress. Hormone resistance is the condition in which hormones are unable to do their actions due to a variety of reasons. Hormones are widely used as therapeutic agents to treat a variety of medical disorders. For example, catecholamines are frequently used in the treatment of cardiovascular, psychiatric, neurological, and other clinical disorders. Hypothalamus regulates the functions of the pituitary gland via hypothalamic releasing factors which may be the release stimulatory factor or the release inhibitory factor. Growth hormone, GH, is expressed from the anterior lobe of the pituitary and produced by somatotroph cells of the anterior pituitary. The actions of GH are mediated mainly through IGF-1, the effects of which are to stimulate growth in bone, protein synthesis in muscle and lipolysis in fat. Acromegaly is due to excessive production of growth hormone in an adult that results in the enlargement of skeletal extremities. The condition of acromegaly is diagnosed by performing two key blood tests, a test to check the level of the insulin-like growth factor 1, IGF-1, and an oral glucose tolerance test, OGTT. Gigantism is a serious condition that is nearly always caused by an adenoma, a tumor of the pituitary gland. It occurs in patients who had excessive growth hormone in childhood. Panhypopituitarism is a condition of inadequate or absent production of the anterior pituitary hormones. Pituitary dwarfism result from generalized deficiency of anterior pituitary secretion during childhood. The two hormones produced by the posterior pituitary gland are antidiuretic hormone, ADH, or vasopressin and oxytocin. ADH release is stimulated by a plasma osmolality greater than 280 mosm/L, stress, sleep, and emotional factors. The main function of ADH is to accelerate water absorption from urine in the kidney tubules into the blood, thereby decreasing urine secretion. The function of oxytocin is to stimulate the pregnant uterus to contract, may initiate labor, and also causes glandular cells of the breast to release milk into ducts. Diabetes insipidus results from a deficiency in the secretion of antidiuretic hormone from the posterior pituitary. Nephrogenic diabetes insipidus occurs when the kidney is unable to respond to antidiuretic hormone. About 10% of cases of diabetes insipidus are of this type. Ectopic ADH secretion is seen when it is released from places other than the hypothalamus and posterior pituitary. The main hormones of the pancreas are insulin and glucagon. These are secreted by beta and alpha cells respectively, found in islets of Langerhans or pancreatic islets. Insulin is the major anabolic hormone of the body. It promotes the utilization of glucose as fuel by stimulating its transport into muscle and adipose tissue. Insulin binds to specific, high-affinity receptors in the cell membrane of many target tissues, example muscle and adipose. Insulin resistance is defined as a clinical state of decreased insulin biologic responses to a normal or higher insulin level. The main effect of glucagon is to maintain blood glucose levels during fasting. Increased blood glucose inhibits glucagon secretion, whereas increased blood amino acids stimulate glucagon secretion.
The main function of insulin and glucagon is to ensure that cells have a constant source of glucose, fatty acids, and amino acids for ATP generation and cellular maintenance.
Diabetes mellitus is a clinical syndrome characterized by disturbance in carbohydrates, lipids, and proteins metabolism. The disease may result from a defect in insulin secretion, insulin action, resistance, or both, and it is characterized by hyperglycemia and glycosuria. Diagnosis of diabetes mellitus: a raised blood glucose can be diagnosed when an adult with a random blood glucose level of 200 mg/dl or more, on 2 occasions. Fasting value of about 126 mg/dl, on 2 occasions. 2 hours postprandial blood glucose level is more than 200 mg/dl in OGTT. Gestational DM, GDM, is a condition in which women without previously diagnosed diabetes exhibit high blood glucose levels during pregnancy. Glucose tolerance means the capacity of the body to deal with ingested or injected glucose. OGTT measures the ability of the body to tolerate a standard dose of glucose. There are 2 biologically active thyroid hormones, i.e., 3,5,35-tetraiodothyronine, T4, usually called thyroxine, and 3,5,3-triiodothyronine, T3. The thyroid secretes about 80 g of T4, but only 5 g of T3 per day. However, T3 has a much greater biological activity, about 10 times more than T4. The thyroid hormone increases the basal rate of oxygen consumption and heat production. This is called the calorogenic or thermogenic effect. Hyperthyroidism, thyrotoxicosis. It affects metabolic processes in all body organs. TSH levels usually fall between 0.4 and 4.0 ml per liter, μ/L, and 95% of cases have high free T4 and free T3. Hypothyroidism in the infant is called cretinism and, in the adult, it is known as myxedema. Calcitonin is the hormone secreted by the parafollicular, C cells, of the thyroid gland. It is involved in the process to regulate levels of calcium and phosphate in the blood, opposing the action of the parathyroid hormone. Parathyroid hormone, PTH, increases the resorption of bone by stimulating osteoclasts and promotes the release of calcium and phosphate into the circulation. The actions of PTH on bone are inhibited by calcitonin, pyrophosphate, and phosphate. Mineralocorticoids are concerned to restrict the loss of water and Na+ in urine, sweat, and saliva. They also increase the excretion of K+. Their main examples are aldosterone and corticosterone. These are exclusively synthesized in zona glomerulosa. The secretion of glucocorticoids is stimulated by ACTH. They act as anti-inflammatory agents and have a significant role in the regulation of the metabolism of carbohydrates, proteins, and fats. The main example of glucocorticoids is cortisol. Androgens are secreted mainly in zona reticularis and also in zona fasciculata to some extent. They possess properties of male sex hormone, i.e., testosterone. They regulate control over rapid growth spurts in pre-adolescence. Dehydroepiandrosterone, DHEA, and androstenedione are the precursors of testosterone, the most potent androgen. Their main function is the development and maintenance of male reproductive organs. Addison's disease is a state of hypoaldosteronism due to the deficiency of aldosterone. Cushing's syndrome, an excess of cortisol characterizes this condition, which may be caused either by a specific kind of pituitary, brain, tumor that stimulates the adrenal glands to produce excess cortisol or by a tumor of the adrenal gland itself, which overproduces the hormone. The most common, 90%, of congenital adrenal hyperplasia is due to the deficiency of 21-alpha-hydroxylase. Conn's syndrome, primary hyperaldosteronism, a condition characterized by increased aldosterone and decreased renin activity, due to certain tumors of the adrenal cortex. The hormones of the adrenal medulla are, epinephrine or adrenaline, 80 to 85% of stored catecholamines, is synthesized primarily in the cells of the adrenal medulla, and another hormone is norepinephrine or noradrenaline, 15 to 20% of stored catecholamines. Blockers and stimulators of catecholamines are used as therapeutic agents. These are frequently used in the treatment of cardiovascular, psychiatric, neurological, and other clinical disorders. Epinephrine and norepinephrine both cause glycogenolysis in the liver and skeletal muscles, which leads to an increase in blood glucose. Dopamine causes vasodilatation in renal, splanchnic, coronary, and cerebral vessels by D1 dopaminergic receptors. It also increases systolic blood pressure. Pheochromocytoma is a tumor of the adrenal medulla, which is usually benign, vascular, and encapsulated. It overproduces mostly norepinephrine and to some extent epinephrine. The main symptoms of pheochromocytoma are continuous or intermittent high blood pressure, palpitations, weight loss, sweating, flushing, headache, blurring of vision, and chest pain. Vanillyl mandelic acid is one of the breakdown products of epinephrine and norepinephrine. 24 hours urinary VMA is raised in pheochromocytoma. The pineal gland and its hormone melatonin are important components of the systems that organize rhythmic biochemical, physiologic, and behavioral processes in living organisms. The thymus gland secretes a hormone called thymosin. This hormone stimulates T cells and other lymphatic organs to mature. Thymosin also plays a role in the initiation of the aging process. Hormones of the gut include gastrin, cholecystokinin, secretin, glucagon, vasoactive intestinal peptide, gastric inhibitory peptide, somatostatin, motilin, substance P, etc. References. Exercise questions. MCQ 1. A 60-year-old man presented with complaints of generalized weakness and weight loss for 6 months. Neurological examination and other symptoms like tremor in hands, arms, legs, jaw and head, stiffness of the limbs and trunk, slowness of movement, impaired balance, and coordination, sometimes leading to falls are suggestive of Parkinson's disease. The possible mechanism for this disease is the deficiency of precursor amino acid for the synthesis of respective hormones in adrenal medulla. Which of the following amino acids is deficient in this patient? Glutamate, glycine, tryptophan, tyrosine. MCQ 2. Which of the following substances is the catabolic end product of dopamine? Homovanillic acid, metanephrine, normetanephrine, vanillyl mandelic acid. MCQ 3. A 30-year-old man is evaluated for an endocrine disorder. Lab results and symptoms are hyponatremia, hyperkalemia, low B.P, decreased heart rate, hypovolemia, acidosis, and diarrhea. Which of the following hormones is deficient in this patient? Aldosterone, cortisol, epinephrine, norepinephrine. Please write answers in the comments. End of Part 4 of 4 of Chapter 23. Thank you.